Hey, everybody. Welcome back to the You're Not Broken podcast. I have my good friend, Dr. Una Lee, on today, another female urologist. Yay. Thank you for coming.
Hello. Hello, everyone. Thanks for having me. It's actually my first time. We've talked about it before, but
We've been
I'm taking the
talking about
leap.
you
I'm
getting
going to
on
do
this
it.
podcast for like years.
I know.
I think
I'm a little,
years.
not that I'm shy. I'm not shy and I'm not introverted, but I'm reserved. I'll say that. And I have a lot to say, but I feel very strongly that it should be said in a way that's meaningful and authentic and in the right space and the right time.
Well, thank you for picking my podcast as the right space for all of your knowledge.
Yes.
This is fantastic.
Yes.
When did we meet? I feel like, have we met before SUFU, which is the Society for Urodynamics and Female Urology, 2000. We met before the pandemic was happening.
Yeah, for sure.
Like, you're just imprinted in my brain at that moment because that's when like the shit went down with the pandemic, and we were all in Scottsdale, Arizona, at a SUFU meeting.
Yeah, we definitely met before that.
We've been in parallel circles. Because
yeah.
CNN was like, this nursing home in Seattle.
Mm-hmm.
That was the beginning of the pandemic.
Yeah. Well, how many years have you been in practice? Have you been out of
14? This year 15. I graduated from residency 2012.
Yeah, so we're in the same cohort. I've been in practice 15 plus years. Yeah.
Hey. How long have you been in Seattle?
Same amount of time.
Same. We're gonna find we're even more alike.
So we are parallel. We are basically the parallel.
Or the same cohorts. I love it. So you've been in academics this whole time at Virginia Mason.
Yes.
And you are now, I'm going to put it into your mouth, you are now the program director. Yeah.
Section head, physician lead. So I don't lead the residency and the fellowship, but I do help lead the fellowship. I lead the department and I lead urologists across the system of Virginia Mason Franciscan Health.
That's big.
Yeah, it's fun.
I love it. So the cool thing most recently is that I quoted your paper when I was talking at HHS.
That was amazing.
Well, it's crazy. So to catch anybody up who's been under a wooden box, I was at Health and Human Services. FDA's underneath So FDA's underneath the umbrella of HHS. Right. So HHS announced the box warning coming off of estrogen products November 2025. And I was one of the 5 speakers on stage. And so they were like, we want a 5-minute speech. Great. Wrote the 5-minute speech. Then they were like, it's a 2-minute speech now. And we're like, okay. So it's not easy to do, to cut a 5 into a 2. But I did it. And what I got to keep in the speech was your data showing if a woman is lucky enough to see a doctor, get properly diagnosed with genital urinary syndrome of menopause, and receive a tube of vaginal estrogen or vaginal estrogen product. When she goes home and reads the boxed warning, 30% of women did not use it because of the warning label, which we all know now was incorrect and has been removed. And that was your paper that you published, which then at the Q&A, I said that statistic, and at the Q&A, one of the in the publicity journalist section of the arena, somebody's like, "Who was that?" Like, they called me on it. They're like, "What was that paper?" And I was like, "It was Dr. Una
They
Lee.
said, "How do you know that black box warning was a barrier?" And you were like, "Because Una Lee's study showed that it was a barrier." And that was the point of the paper, was that fear, misinformation, and cost were barriers to women receiving treatment for GSM, genital urinary syndrome menopause. And we surveyed 1,500 women across the country. And that was some of the findings. And sometimes we do research to demonstrate what we know. We know that, you know that, right? You see that all the time in your practice, but we needed to have the statistics to show it. And so that's why we did that survey, to show, because we wanted to document what we experience in our practices and what we see. So yeah, that was cool.
Well, it made a world of difference.
Yes.
So I was like literally on stage quoting your paper to the dude who was like, right. And in my head, I'm like, hold on. Why don't we have more of this for the systemic hormones? How many people don't use it? And to think of actually how unique your paper was, because they were like, what? It was it's not been published how many women don't use these medications because of the box warning. Like, it was a very unique data point. And to me, I'm like, would I have, it takes these intersections, right? Of
Mm-hmm.
like the fact that I'm a urologist, I read urology journals, I have
Mm-hmm.
urology friends. So I knew about that paper. And at the
Mm-hmm.
same time, I'm in the menopause advocacy hormone world. It
Mm-hmm.
takes those, the Venn diagrams to be
Mm-hmm.
able to pull it all together.
Right. And I kind of remember when that journalist raised his hand, everyone kind of looked at each other like, well, I don't know. And you were like, I know. These are the facts that have been in our literature, that the fear of side effects that are promoted in that are a barrier to women not only actually using the treatment, getting the treatment. There are access barriers, right? But they have to actually put it onto their,
Yeah. You know what
tissues to
I'm
get the
seeing
benefit.
right now, and I need to create more content about this. Is women are getting the prescriptions now, and it's been an explosion since the HHS and the box warning are coming off, like, which is crazy in and of itself, because you're like, estrogen actually didn't become safe on a Monday, right?
Yes.
Like, it was
Yeah.
actually always safe, but now doctors are like, and I get it, we're busy, blah, blah, blah. But it didn't become safe on that Monday. It's been safe for decades, but because
Yes.
of that Monday and the social media and the CNN and like the knowledge explosion from that Monday, estrogen's safe again. And so the prescriptions are happening, but the barrier now is a doctor does not have time in their office to educate on how to use this product. And this product requires some troubleshooting.
Mm-hmm.
For example, do you know what your vulva is?
Mm-hmm.
Right? Like,
Yeah.
there's a
The
lot of
anatomy.
knowledge barrier toward it. So on my Instagram, I get a lot of people being like, I got a prescription. What do I do with this thing? Right?
Yeah.
And it's like, we
So
don't have
that was
time
actually,
in the clinic to teach on this.
yeah. So that was actually one of the first papers that we did on GSM, is that we went on Reddit and we read every single post that patients, users talked about GSM. And it was fascinating. And then we did a qualitative analysis, which is like basically reading and looking for themes and quotes and kind of
I
patterns.
call it Brene Brown research,
I love it. It's like, to me, it is
because that's her.
patient-centric.
Yeah, it's her whole
Right.
shtick. Is like, let's listen to a bunch of stories and see what we learned from it.
Yes, and that's
Yeah.
what it is. And honestly, that's the kind of research I'm leaning into right now, because I want to better understand the patient human lived experience so that we can meet your needs better, so that we can help you, so there's not a gap in understanding, and that we can meet that gap. So
So what'd you learn
we
from
read
the Reddit GSM?
the Reddit GSM. It wasn't a GSM thing, but we searched for everything they wrote about it. And number one, they were engaged and passionate and knowledgeable, but they had a lot of questions about the medication uses, the alternatives, the fear of side effects, the fear of cancer, right? All the things that we kind of hear from our patients, but it was over and over and over. And, just a lot of practical things like, how do I do this and have sex, right? Do I have to take a break? Da, da, da. Like, very
Big
practical
questions
things.
about how does it affect the man. Big questions. And like there's a paper on that. They studied it. They studied men's, for anybody who wants to know the answer to that question. They took men's blood levels before and then 8 hours after having sex with somebody who had vaginal estrogen product in their vagina. And it does subtly raise the man's estradiol level, but not above a man's normal estradiol range. And then people are like, men have estrogen? And you're like, yes, men have estrogen. So
Yes.
I always say don't use it as a sexual lubricant, but
Yes.
if
And if you can't avoid it that evening, don't
it's
use
fine.
it that evening, right?
Yeah.
Yeah, but it would be fine.
Yeah,
It's not going to
it would
harm
be fine.
anyone.
Yeah.
And so what I learned from that was just that, again, that patients had a big fear of the side effects and the fear of cancer. And I think that's a very real and deep-seated emotion in women, is that they don't want to cause any harm, right, to their bodies. And because they felt like this was causing harm, they were like, I'm not touching it. And we know
Yeah.
that's not true.
Yeah. But that's a very interesting one side of the coin, because the corollary is we cause harm. We can, not always, this is not 100% of people. There is harm done to the pelvis and the vagina and the vulva because of low hormones, whichever way you have hormones.
Yes.
Right?
Oh my gosh.
So there's harm by not treating, And yes, there are always risks with any medication. But what I hear over and over and over on social media is nobody told me my vulva was going to disappear. Nobody told me my labia was going to disappear. Nobody told me my orgasms were going to change. Nobody told me that sex was going to be painful. Like the harm that happens from living without hormones, nobody told me about that either. So then you're in
And
a balance. You're like, well, which
yes,
harm would you like?
right. And we know that the benefits outweigh by far
Yes.
100,000 times. But, I don't think people realize that your vaginal, because I do vaginal exams every day, 20, 30 times a day, and the tissues look and probably feel terrible to that person, right? Pale, red, fragile, bleeding, uncomfortable. That's what happens untreated,
Yeah.
right?
Right.
And we have great treatments.
Yep.
So it's interesting that a woman would rather suffer with that than apply a product that is
And
safe
I
and
think even
effective.
the stigma that it's a prescription. Met a woman in Texas who built a special cupboard in her kitchen for her supplements. That's how many supplements she buys, but would not do vaginal estrogen because it was a prescription. And having that conversation of what are you making it be a prescription mean
Yeah. I mean, just the
versus,
stigma of hormones.
yeah, I know. It's
But
wild.
anyway, so that study was helpful to just really get deep into that patient perspective. And then actually the study that you quoted at the HSS presentation was the follow-up study, because I was like, oh, this is fascinating. And I want to document it in a more quantitative way. So that study was take a big sample and ask these questions that were generated from that study. So that's kind of, each study generates the next study.
I
And
love
so
it.
that's
Okay,
how
so
that
this is
happened.
what I need. This is what I need from your team. Delegate as your time allows. I need a quantitative study on women's opinions about taking testosterone because they want to talk and nobody's listened and done a Brene Brown on that. Can you do a Brene Brown on women's experiences taking testosterone? Because there's lots of fascinating things going on there. The other thing I need is I now can talk to HHS people. And so I was having a meeting after that Monday, and I was like, we need a female dose testosterone. It is ridiculous that we're microdosing and we're pelleting and we're compounding. And he's like, yeah, but is there really actually a need for it? I don't have any receipts. But to the best of the experts' knowledge, there's as many women in America on testosterone as men are on testosterone. But we do not have receipts on that. So I need some more receipts.
What do you mean by receipts? Like data, info?
Yeah. Because
Yeah.
how do you count? You can count in a Medicare database how many people take Ozempic. But when Ozempic's compounded, you can't measure that.
I see.
Right? So when you're taking a male dose testosterone or you're compounding or you're pelleting, you can't count that. There's no database. Right? So I can tell you how many men are on a testosterone prescription, but I can't tell you how many women are on a testosterone prescription. And that's a disservice to the women because they're hard to count.
Yeah, because you're not getting the.
I put that in your brain to think about. That's what
I'll
that's
think
what I
about
need.
it. I'm gonna ponder that one. We
We're gonna
did
ponder.
debate it highly, very vigorously at the GSM guidelines panel,
Yeah.
and the data was reviewed. I don't think it made it into the guidelines, but it is the data is accumulating and will be followed very closely. It's
Vaginal
promising.
testosterone? Or what are you talking about? What's being debated?
Testosterone. No, it's a good question. I don't know if I know that. Testosterone in general
Okay.
for women.
Well, because
Yeah.
vaginal testosterone is different than systemic testosterone, just like
Yeah,
vaginal
yeah.
estrogen is different than systemic. So I'm like, what's the GSM guideline people doing with systemic testosterone? Great if they are.
I'm
Thinking
not
about it.
sure which one. Yeah, I'll think about it. I'll have to
Just
look
thinking
back.
about it. So now that, I mean, I think people who listen to me know that there's GSM guidelines. I've had Dr. Rachel Rubin on talking about it. She's very vocal about it. It's phenomenal just in the validation of how women can advocate for themselves when they go to the doctor. So now I say, print out the GSM guidelines and bring it into your doctor. As a society, as a team that wrote the GSM guidelines, how do you see it best that information shared so that the primary care doctors know that there's guidelines, that this is legitimate and very effective and very safe? Like once it's written, how do you spread it? Because it does no good to just sit on the AUA website if nobody knows to read it.
Well, I think the black box warning coming off helped a lot because it was in the lay press. And so primary care is now reaching out to me on education, and they want to embrace it and they feel like they can. And so I think it's definitely education, awareness. Absolutely. Primary care, general gynecology, general urology. I mean, lots of subspecialties could take this on and embrace it and see and manage women with this issue.
I do not mean to put you on the spot, but there was a recent paper just published in JAMA out of Stanford looking at Medicare databases up to 2018. And a couple of takeaways from it. Number one, if you were lucky enough to be properly diagnosed with GSM. So these are like, think of all the suffering women and how many actually go to the doctor. Okay, so there's a fraction, right? And then you go to the doctor, did you get properly diagnosed with GSM or not? That's another fraction. Of the people with a GSM diagnosis, what percentage of them got a prescription within 18 months of vaginal estrogen? Do you know that statistic? Have you seen this paper?
Tell me.
You want to guess? 9%. 9%. So think of that funnel. Think about this is how undertreated GSM is. Of like, you actually went to the doctor. You actually got the right diagnosis. So this is diagnosed with GSM, 9% got a prescription for vaginal estrogen. Now, one can hope that it's better now than 2018.
Yeah.
One can hope that. The other shocking thing about that paper was, guess what the third top group of prescribers was? Urologists. So it's like, and there's not a lot of us. So you're like, if we were the top, like you had to get to a specialist to get your vaginal estrogen, right? Like that's how undertreated. And we know GSM, 50 to 80% of women will experience it.
Oh, yeah. The prevalence is high. It's almost like you have to assume you have it. It's a combination, right?
I mean, the question
signs
is,
and symptoms.
How are some women not getting it, right?
Mm-hmm.
I think some people just have a little bit more estrogen in it. In them, it's funneled to their pelvic structures. But like in a state of no to very minimal hormones, how do some people not have GSM? Is the more interesting.
There are women who
question.
have the appearance of GSM on exam and no or less symptoms. There are people who look healthy and have symptoms, and there's every combination in between, right? And the symptoms are a constellation, right? But I would say if someone's walking into my office 50 plus, 45 plus, I assume that that's a factor in their situation, especially because they're walking to my office, so they have something going on.
Well, for any urologist or any pelvic floor person, urogynecologist, et cetera, and this is, again, going into the Venn diagram of knowledge, because where is the paper published that vaginal estrogen is equivalent to anticholinergics? Where is that paper published? The Journal of Menopause. How many urologists are reading that journal? 5, maybe, which is 5 more than 5 years ago, right? So it's like that overlap of they didn't publish the anticholinergics equivalent to vaginal estrogen in the urology journal, but who sees the overactive bladder patients? So we just have to get if you're a pelvic floor person, think vaginal estrogen when women come in with recurrent UTIs, overactive bladder urgency, dysuria, all of the things, microhematuria.
And think about all the women who get treated and they come back amazingly better, right? Like it's such a rewarding part of a clinical practice or as a patient to have some of these symptoms going on and then you get treatment and 1, 2, 3 months later, you're like, I'm so much better. That was life-changing.
I gave up surgery for hormones. That's how life-changing it is. And pulling out a distal kidney stone is pretty damn rewarding, in my opinion.
Yeah.
Right? I was talking to somebody about this yesterday of the 1,000 little cuts that made me become what I do now. Is this woman came in, she had bladder cancer. It was a low risk, just superficial bladder cancer. Took it out, was doing her surveillance cysto, just fine. Bladder cancer won't come back. It was super low, minimally invasive. And she's like, that's nice that you cured my bladder cancer. Thank you. But that's not what changed my life. You gave me vaginal estrogen. I had seen 2 nurse practitioners, another doctor for my recurrent UTIs, the absolute pain with sex. They just kept throwing antibiotics at me. Nobody helped me. You gave me vaginal estrogen and my life has changed. I'm all better. And I'm like, here I am curing bladder cancer. And that wasn't the most important thing to her. Right? It's like those stories are the stories that change your career.
Well, that's also, again, all my research has evolved over the years to be patient-centered, because what really matters is not what a scientist thinks, not what a researcher thinks, not what a doctor thinks. What we think the research questions are, the outcomes are, the studies are. There's tons of amazing scientific literature. But what really matters is what patients need and want. And it's been mind-blowing in a great way to change the paradigm. And so It actually all started with mesh. That's why I
Let's talk
switched
about it
all
because
my
that was
research. Yeah.
mesh, and the mesh paper was the reason I wanted you on the podcast to begin with, like, years ago.
Mhm. Mhm.
So both of us trained, now that we know that we trained at the same age, both of us trained in the world of pelvic mesh kits for pelvic organ prolapse. It was an extension of hernias, right? So male inguinal hernias, they use mesh because it's stronger than your body. And they thought, well, let's put this down in the structures surrounding the vagina and see if it makes prolapse, which is a descent of the pelvic organs through the vaginal canal. Let's see if that makes that come back less. Because if you get a surgery for pelvic organ prolapse, recurrence rate is around 10%. Plus or minus, now we have robotic sacrocolpopexies, which are even better. But putting mesh in via the vagina, so that's via the pelvic vaginal approach, was probably the standard of care for a while. So we brought it in and then we took it back out. That's my little history lesson. Please add or correct as needed.
Okay. So yes, that we trained in an era. I trained, you know, in an era of where we saw mesh rise and mesh decline, right? In the use in the pelvic floor. It's used for stress urinary incontinence, a midurethral sling, and it was used for prolapse in two directions. Either put in vaginally through the vagina with big sheets or put in abdominally to support things. So three different uses, and we kind of think of it as one bucket, but it's really
We
three
just say
buckets.
mesh, but it's best to
I know.
specify when we're talking about risks. Yeah.
Yeah. So it started with slings, right? 97, 98, the midurethral sling was brought on the market after some study, and it revolutionized the care of women who leaked, right? It really was more durable, more effective than the prior procedures, which was the Birch procedure, which was a suture-based stabilization of the urethra. And millions of women benefited and continue to be benefit from this. But the the problem was twofold, was that these mesh kits got introduced under the sort of same process, like saying, oh, they're just like slings, just let us do them. And they got put in willy-nilly into probably poor candidate people or lots of different reasons they were put in. And the complications rates were too high, 20, 30, 40%. That's way too high. Eroding through the walls, pain with intercourse, bad problems with the mesh in that category.
For pelvic
And then
organ
what
prolapse, vaginal
for
mesh
prolapse?
specifically.
Yes. And what happened is millions of women who had midurethral slings successfully, portion of those, 2 to 6%, had problems with mesh slings too. And unfortunate, but you can have a complication. Anytime you're putting polypropylene mesh, which is essentially plastic, for all the benefits and all the great things it does, there's also a subset who's not going to do well. And it's going to have complications. When you take on surgery, and I don't know if patients really realize it, is you take on all the good, the best case scenario, and you take on the worst case scenario too. You consent to that. You consent to all the 90% success rate, but you also consent to the 2% complication rate. And so what we saw was women who did great with slings, but you also said women who had horrific pain, horrific erosions, horrific obstruction, can't pee, difficulties. And so I trained at places where we saw a lot of these complications and managed them. And then I moved to Washington State and I continued to help women with this problem. And I just had such a heart for these women. I really believed them. I really listened to them. I could really help them. And they often couldn't find help other places, right? People didn't believe them. People didn't listen to them. People didn't want to help them. People didn't have the skills to help them. So I get it. It's not like a judgment. It was just it's a difficult situation. Some of the women had slings who didn't even need a sling, right? There's something called a prophylactic sling or a preventative sling. Like,
We did that for a while. It was like, and there were studies on this of like, if you put in a midurethral sling at the same time as prolapse, they were less likely to have stress incontinence after what we call unmasked stress incontinence after the prolapse was fixed. So sorry for anybody who needs intro 101 on pelvic organ prolapse. I do have a previous podcast. We kind of brought everybody in at the 301 level today.
yes,
But for the people who are already educated, they can handle this. I got a lot of smart people. So they did that for a while. They just put in midurethral slings at the time of pelvic organ prolapse because a risk of fixing especially severe pelvic organ prolapse is that you unmask stress incontinence because you're kind of not kinking it off with the prolapse. So anyways, they did that for a while. And then it kind of got to the like, well, if you leak afterwards, then we'll think about doing a sling. Not that the surgery failed, but it unmasked this other issue that you had.
Right. So, your experience, my experience, we've seen lives uplifted and, such benefit from treating their prolapse and their incontinence with or without mesh. We've seen lives devastated. Right. And so the pain that I have firsthand, like, walked aside patients with. And so I've taken out so much mesh from, surgically, and I've learned so much from it. And patients have learned, doctors have learned, we've all learned a lot from this process. But some of the things that we've learned is that, the informed consent process and the surgeon patient relationship is paramount. You really have to know what you're getting into, and patients need to be properly selected, properly counseled. Not everyone's a candidate, right? Some of the worst complications were in patients who I kind of thought like, and I did a study on this high level of, immunosuppression, obesity, other comorbidities, chronic pain conditions, psychiatric conditions. For whatever reason, these tissues did not like this foreign body. You know, it's the pelvic floor, it's the urethra, it's the vagina, it's the bladder, it's the rectum. These tissues are sensitive. And to think that you could put sheets of plastic in a sexually active, physically active, urinary active, bowel active organ is a big supposition.
It's a big
right?
deal. And I think, the other thing, just as far as violation of surgical principles, let's go back to our GSM data on how many women with genital urinary syndrome menopause are actually getting treated for that, right? So now we're putting in surgical mesh, creating an incision, putting in a foreign body in tissues that are substandard because they've never been optimized. And we know, pick an area of the body, you want as good of a surgical real estate as you can be, and how many of these really bad surgical mesh complications are in atrophic pelvises that were never given vaginal estrogen for treatment in the first place. And to me, I'm like, if you have mesh in your pelvis, you have vaginal estrogen until death do you part. You've got to keep your tissues healthy, resilient, thick, well vascularized. Like, that's part of the responsibility of taking care of your pelvis post-surgery.
Right. And your tissues evolve. You maybe had a successful sling 10 years ago, and as your tissues
When you were 47.
lose the level of estrogen, the erosions come through the tissue, the literally fibers of the polypropylene mesh come through the wall, and it hurts. It's not pleasant. It's discharge, bleeding, pain, uncomfortable. People are kind of confused, like, what's going on? So mesh in itself isn't bad, right? We use mesh for hernias, but that's a different part of the body. That's the abdominal wall. Is that wall having sex? Is that wall, lifting groceries? Is that wall like peeing and pooping?
Pooping and peeing around it? Yeah.
Yes, that's like, to me, it's a very intimate part of the body with a lot of sensitivity. And, I think I'm not against mesh. I'm not, I use midurethral slings. I use pulpopexy mesh to fix prolapse. We just have to be judicious and careful and, have such respect for those tissues and when we're using it and how we're using it, and not just willy-nilly put it in people, which I don't think people really did. But at one point in that peak, it was getting put in very rampantly and that's the lesson. I think there's a lot of lessons, is that you have to have the experience and stick with your patients. If they have a problem, believe them, examine them.
And please know
listen to them.
about the effects of low hormones on pelvic structures if you're going to be a pelvic surgeon. Like,
Mhm.
come on. What's very interesting about that is in the equivalent, what's a kind of an equivalent surgery in men? I would say the inflatable penile prosthesis. So it can be life-changing for people. This is for severe erectile dysfunction. So it can be life-changing for people, but when it goes bad, man, it goes bad. You've got plastic tubes jutting out the tip of your penis, infections, removal, right? Complete impotence afterwards. Like, when it goes bad, it's bad. When it goes good, it's good. Now,
Mhm.
when a man has a bad penile prosthesis surgery, do we ban penile prosthesis surgeries for all men everywhere in multiple nations? No, we don't. When women have bad pelvic floor prolapse options, do we ban these? Do we get rid of all the kits? Yes, we do. And we got rid of the midurethral slings in multiple countries after this happened. And my thesis is the level of risk tolerance in men versus women is different. The rules are not applied equally. Because when a guy gets a plastic rod through his penis, we don't pull it out of countries because we say a man's sexual health is important. Of course, that's a risk. So these are the things I think about as a urologist in implying the gender disparities and how we think about risks and what's tolerable. This is for a man's sex life, let alone like you can't urinate in a woman, right? But a man's sex life is important. We're not going to ban these surgeries. So has that ever crossed your mind? Like they pulled midurethral slings out of multiple countries because of this, when the pelvic organ prolapse mesh was really the big beast.
Yeah. I mean, I have a heart for this area. So, obviously wide restrictions aren't, it was a pause. And I do think hundreds of thousands of women's lives were devastated. And so the sheer number, right? Because if you think about the prevalence data, right? Like, yes, penile prosthesis is a small number, right? And so they can manage this. It's not like a public health issue. This was an FDA, safety issue. Because if you think about it, millions of slings have gone in over time. And if my calculations are 2 to 6% have some form of complication, that's still hundreds of thousands of women. And as you know, there was litigation and all this stuff. So I do think it was real. It was real, and
it was big.
It was big by the numbers, because if you think 50% of women have incontinence, many women have prolapse, and not as many as incontinence. Honestly, it's a smaller number, but just by the sheer number, that level of and it just mounted. It just hit a tipping point where it affected so many women that they had to pause and figure out what was going on. And
but to remove midurethral slings and they didn't remove it from America.
They didn't remove them from this country. So
Not
they've
from
always
America.
been safe. Yeah,
yes.
They're safe in this country.
But, then I hear from the British ladies and the European ladies, and they're like, I'm just peeing my pants. I can't exercise. Like, This is not cosmetic, as much as I don't want to dismiss cosmesis.
No, it's not.
But,
it's not.
This is a legitimate medical problem where options were taken away. Now, I think the silver lining of that is Bulkamid became a thing. They developed a better bulking agent. I know you do Bulkamid. I love Bulkamid. But so when the gap opens,
more options, more safer, different options. Yeah.
Come in, right? So I think that's the good thing. Well, let's talk about the workforce. 30% of women will have bladder leakage. Pelvic organ prolapse surgery is becoming, because hysterectomy rates are going down, pelvic organ prolapse surgery is becoming one of the more common surgeries a woman will need in her life. But we don't have many trained, and think of how many people are untreated, right? We don't have a workforce to support the aging population with pelvic floor issues, and it's not getting better. I'm part of the problem also.
You have other gifts you're giving to the world.
I have other gifts.
I see women with prolapse and incontinence every day, and it is highly prevalent. People don't really talk about it, and they feel a lot of validation when someone listens to them. And I think that's another theme I would talk about, is just patients, women. I mean, I see women, a lot of women, but they want to be heard, listened to, acknowledged. And that means everything. I think if you can listen more than you talk in a visit and really try to understand what their priorities are, what their problems are, what their goals are, they will really appreciate that. And I think prolapse and incontinence and GSM and mesh complications and overactive bladder, all the things that we deal with, recurrent UTIs, pelvic pain, all the things we deal with are areas that have been marginalized and not, hard to find good care and hard to find answers sometimes, right? It's not an easy peasy thing. It's multifactorial.
It's tough. It is the pelvis is complex. Not that I'm like, and so is the neck. Like there's lots of complex parts of the body, but the pelvis is complex. And like you said, you have to have sex through it, poop through it, pee through it, not get it infected, right? Like,
yes.
A lot of players.
It is the basis of everything. Your body's resting on it, right? And so when you talk about someone being physically active, if this isn't working, how can you be physically active?
Yeah,
right?
And like a hip issue will throw off the bladder, right? Like everything can destabilize the pelvis as well. But yeah, we've got to, I sent you a text, which I have not validated, but it was like the amount of urology jobs currently posted is 10% of the urology current workforce.
There is a workforce.
We have a big workforce issue.
Yeah.
Urogyne is helping on their end, absolutely. Pelvic floor physical therapists, God bless them,
Mm-hmm. Powerful.
essential. I mean, how many patients came to me that's the other interesting thing. How many patients get to me, the surgeon, with surgical options before they've seen a pelvic floor physical therapist? The patients don't even know these people exist, but it's like perhaps the referral to pelvic floor physical therapist because they fix a lot of things.
Mm-hmm. How many people could be cured with engagement with a pelvic floor physical therapist and doing, and they want that. Patients want that. They want the natural choices when they have the options.
Yeah, yeah. I
And
would say in
it's
my
just, it's,
experience, they either want the quick fix, they think surgery is a quick fix,
hmm
which like you said, you gotta take the wins of the quick fix with the not wins of sometimes it's not a quick fix at all, and it's a path, it's a road. I think that's why, and I think a lot of patients don't know about pelvic floor physical therapy, or they didn't get referred there before here.
that's my current research. It is a 2-year funded patient-centered outcomes research initiative to disseminate evidence-based information about the efficacy of pelvic floor physical therapy for urinary incontinence in women. I know there's a lot of words, but basically, we are trying to get the word out there that pelvic floor physical therapy is a valuable, I will say, first step for any women with urinary leakage.
Yes. Wow. I mean,
And so
I have like
it's a collaborative kind of project, and we're working on getting the word out.
I when I first moved to town, so like 15 years ago,
Hmm.
you're like, you think like what you did. You did like strange things in your past. You're like, oh, really? I did that. Good job. But the pelvic floor physical therapists in town are still like, we remember when you came into town and you came around and had coffee with all of us and introduced yourself. And I'm like, I did that. But it's like it meant so much to them. But to me, I was like, I knew that from training. I needed to know who these people were. I needed to like get them into my team because they weren't in my building. Of like they're part of pelvic floor health. I don't think you can have a pelvic floor health conversation without pelvic floor physical therapists. I certainly wouldn't want anybody to have that conversation without the pelvic floor physical therapist.
Right. Yeah, when you have an orthopedic injury, you know that the options are going to be physical therapy or other options, right? And people accept that, like, oh, if I do the physical therapy and if I really stick to it, it's going to get better. It's the same way with the pelvic floor. And what's been mind blowing to me and very helpful to me is I've actually talked to a lot of physical therapists through this project and learning more and more about how it's advancing. It's not just Kegels, right? There's so much more that they're offering, and, you know, breathing, managing pressures, how to work with what you got. It is
Yep.
not just strengthening. I heard a
No.
really interesting thing. She said Kegels were designed like in the 90s when women were not physically active. And so they were
Fascinating.
made to it is fascinating. It was like a different generation, right? And it was revolutionary at the time to be like, do these exercises and strengthen. Well, now our generation and generation above and below us are more active. And so we don't need the strengthening, not everyone, right? That's why you get people who say it didn't work because they're like, the muscles are strong, but how do you use them and how do you manage the pressure and all the sensations in there so that you don't leak or so that you don't feel the way you do? And so there's a kind of a new wave of physical therapists who are pushing the boundaries. And I love it because there's much more than Kegels.
I think that's so great. I mean, everybody asks, like, people ask me all the time because there's so many pelvic floor trainers available now with like apps on your phone. And they're like, what's
Yes.
the best one? And I'm like, I have no idea what the best one is. I'm not sure like, how could you be, unless you own stock in one of the companies, how could you be so certain there is a best one for everybody?
Oh, I think it's
Right.
very individualized.
Yeah.
And
I
it's
think it's very
also,
individual.
and you need to, and again, that's why you need access to these specialists. They're also in high demand and there's poor access issues, but you need to individualize it to your anatomy, your needs, your goals. And sometimes I worry some of these products are, what is it called? They're trying to make money on a need that
I
is,
was going to say
and they're,
predatory, but I didn't want to
yeah,
sound
yeah,
too
that's the
aggressive.
word, predatory, but there's all kinds of predatory stuff in our field, right?
Well,
They're
it's super
predatory.
interesting. Yeah, you go.
Well, I think that's an area where people can spend a lot of money. Patients come to me and I spent this much money on this, and then they're still coming to me, which means it didn't get it resolved, right?
Yeah. Yeah.
So, and I see a lot of predatory products around, as you do, around pelvic floor physical therapy, and I think the theory of it is good, right? Bring it into your own home, like make it more personalized, engage and gamify it, but I got to wonder. And then the other big one is recurrent UTIs.
Yes, totally.
I worry that they're spending money on things that are like not evidence based. As long as they're not doing harm, I'm okay.
If it
Right?
helps you drink more water,
Then yes, I'm all
maybe it's
for it.
working, right?
Yes,
But you better
yes.
be on the vaginal estrogen.
Right. But I don't
Damn
want you to
it.
spend thousands of dollars or hundreds of dollars on
No.
something that.
God, please don't. I think the other thing is and again, it's the sides of the coin, right? Because we've got two arguments going on. We've got this one argument that says nobody's paying attention to women. We need more innovation. We need more products. We need more things geared towards women's solutions. Other side of the coin. But now we're preying on women and we're just making money off of women. And I'm like, aren't we actually trying to solve the problem of nobody paying attention to women? Right? So I'm like, I don't think you can flip to that side of the coin without some of that. I don't think it can be
Right.
done perfectly.
No. At least they're in the
but
space.
yeah, but the opposite of where we've got all these predatory solutions is we've got no solutions. Right. So I think about that because I think especially the internet is so quick to say we're not doing enough and now we're preying on you. And
I also think another struggle is we'd say go see a specialist. You know, whether a specialist physical therapist, a specialist pelvic floor person,
specialist hormone person.
Yeah, specialist hormone person. But the access is so hard, right? Like I wish
don't need a dermatologist. That's real bad.
But my wish is that people would have better access. But I can't personally do all that. I want to, right? But so how do we create better access to high quality, safe, patient-centered care?
I think you have to change the profit drivers and you have to not burn out the people. Like that's the thing is like, we're trying to replace everybody with AI. We're trying to replace everybody with less trained people. Like there's flaws in that system without saying, let's address the burnout. Let's address the malpractice issue. Let's address the reimbursement issue. Let's address the fact that we've got a surgeon, but we didn't provide any support staff for that person. So they're doing it all, right? Let's have them work at the top of their license. So it's so multifactorial, and I think these simple solutions aren't going to actually solve it without actually looking at the culture that we've created.
Yeah, healthcare has a lot of big problems, and that's one big one, right? Access and what's doing the right thing for patients and keeping that at the center.
Yeah, well, and at the same time, like I'm probably overgeneralizing, but the society is getting older. This is all true data. We're getting older. We're on multiple medications. We have multiple comorbidities. I mean, people joke, they're like, the cardiologists have done such a freaking good job of keeping people alive that now we actually have pretty sick people who have significant pelvic floor issues or urology issues or kidney stone issues or ankle issues, whatever they have. And so it's like, we weren't even trained. Were you trained? Do you remember? Were you trained? Like, how do we deal with somebody who's freaking complex, right? Like, it's like this level of complexity that I don't think any of us got that training for, but that's the world we're working in now. Like, what do you do when they're on 14 different medications? Like, how do they all, this is complex stuff.
I do think the silver lining to bring it back is that I think there's consensus that vaginal estrogen is safe and that it's effective. Everyone agrees. And that's why the black box warning came off. That's why people have energy around this, because there are no naysayers per se.
It's the lowest hanging fruit. There were naysayers. And to me, I'm like, of course I heard them because I was on stage, right? Like that's my job. I get to hear the naysayers. And some people did want to make this political. They're like, they just decided. And I'm like, there was no, and then to me, I'm like, it's such a lack. It's a lack of knowing, but it's also a lack of respect for all the people who tried to do this for the last 2 decades.
Yes.
And then they saw me on stage and the 4 other people on stage, and they're like, they just decided to do this. Of like, we stood on the shoulders of giants who have been yelling this and actually doing the research, publishing the data, like going to the FDA for the first time, going to the FDA for the second time, right? So it's like, I got to be super fortunate to take it over the finish line, but not without the baton being passed multiple times to finally land in my hand.
Yeah, it was definitely a huge collaboration. There's a big history. This momentum had built up over time. And I think even you think about the serendipity of, urology taking this on. Actually, I had a gynecologist right, who talked to me about this. And she said, it's interesting. I've been part of the Menopause Society for so long, and we had a hard time achieving this. But the urologist got involved and it helped. But I think what really I thought about what she said, and I think it's because GSM the evidence was so strong and had built up over time. Not that the that the systemic hormone data is also very compelling, but it helped that the urologist did the guidelines, that we looked at the data, that it was safe, that it's a ubiquitous problem that people could get behind. Absolutely, there is strength behind the hormone data too, but it's a little more nuanced, right?
Mhm.
Whereas I
Yep.
feel like the safety profile of vaginal estrogen for GSM is
Low hanging fruit.
like, it's very easy peasy. You can say it's safe. You can say it doesn't cause cancer. And that is the truth
Yeah. Yeah.
and effective, and it works.
100%. Yeah, totally. I mean, it's over the counter in multiple countries. I think not this year. We've got some other big advocacy projects that we're working on this year. But I think very quickly in the future, there will be a push to make it over the counter because of the access issue, right? Like
Mhm.
what you've been saying of like, we say see a specialist, we say see a blah, blah,
Mhm.
blah. But even Medicare, known diagnosis of GSM, only 9% got vaginal estrogen, right? And making it over the counter to say, this is safer than Tylenol. This is safer than
Yeah.
some over-the-counter things, right? This is
Yeah.
safer
We
than
have to give people that
ibuprofen,
responsibility. Yeah. Give
right?
people the trust and responsibility.
Yeah, and to say because of an access issue, should this because of an access issue and because it's so safe, should this be over the counter? And I think that's the case that we'll be building. One more question before we end. The genital urinary syndrome menopause guidelines that people can search for on the internet. It's free. You can print the whole multi-page thing out and bring it into your doctor. Do you have a patient-facing one page?
We're working on it. Absolutely. Yeah. The A-Way Foundation is absolutely working on it. They're the
Perfect.
patient education part of it. We need patient
Yeah,
facing
it needs to
versions.
be
And
right next to the link of the GSM guidelines. There needs to be the
Mhm.
patient-facing one so that they can.
Yeah, I
Because
love that.
when I say print it out, it's a lot.
Yeah. It's made for, it's like dense.
It's made for
And honestly, a lot of our medical literature is like that. That was one of my findings about this, is that we have great data on a lot of these things, but if you don't make it patient friendly, you don't make it patient facing, how are they going to absorb it?
if you keep it behind
So
a
they need,
paywall. Yeah,
yeah,
totally. Well, that you know my career. I'm patient facing. Like
yeah.
you can change the world by publishing, by teaching your peers. You can also change the world by educating the average person, and
And they're all important,
it's
right? Like
all
everyone
it's
has their,
all important. And
we're all
you
kind of
can't do
rowing on the
one.
same.
Yeah, it's like you can't do one without the other one. And I mean, I truly think patient education should be the third pillar of academics. We do the research, we take care of people, but we need to educate people because they don't know. And so it's like it's that what social media and podcasts have allowed doctors to do to reach many patients. I'm like, the academics should take that on as a third pillar of academics. I'm like, we don't just teach the next nurses and the next PAs, but we teach the people. Dr. Lee's going to
I like it.
she's going to think about that one.
No, I agree. I 100% agree. I think there's different ways to educate, and we need it all.
We need it
We
all.
need it all. Public facing. I just was thinking about, I educate patients one-on-one in a clinic room, and that's super valuable. But if I could amplify that and bottle it up, and you know, what the impact of that would be. We amplify things through research. We amplify things through teaching the next generation. But yes, 100%. I think that education is power, and I want people to be very informed about these intimate parts of their bodies so that they can lead these fabulous lives, right? Another thing I've learned from all my patient-centered research is that it's about quality of life. Patients want to improve the quality of their lives, and that's what they see, that's what they're seeking. And so once you realize that that's their priority, then what can I do to help you improve the quality of life? What little step can we take forward together?
I mean, that's
Can I
super
help you?
interesting.
Can I guide you? Sherpa, I'm your Sherpa.
Are you ever going to get any medication FDA approved for quality of life? No, that'll never happen. Right? So there's a fundamental disconnect in how the system works and what people want. And I think about that a lot with testosterone, right? Like it fundamentally improves quality of life. Why do you think it's gangbusters fire on social media? Because it improves people's quality of life. But it's hard to measure. You will never get it FDA approved for quality of life. But that's why it's so big right now. It's a quality of life improvement.
Yeah.
We could talk for a whole nother hour.
We could talk forever. We could talk forever. I love it.
Well, whenever you ask me to do anything, I always try my very best to say yes to you. So
And
whatever
vice
you
versa.
need.
Thank you for
some qualitative research on
me.
women and testosterone, though. I'm going to be a bee in your bonnet on that. Now that I know you know how to do that research.
If there are people out there who would be my little army of worker bees, then we can make that happen.
Ooh, very nice. We will talk offline.
Yes, let's do.
We'll find some. All right, my love. Until next time, thank you for your time.
Thank you, everybody.
Okay, bye.
Thank you.